So without further ado, I'm going to introduce Dr. Carey, who's going to do the next session. It's a privilege for me to introduce Lisa, who's the Distinguished Professor in Breast Cancer Research at UNC, the prior chair. She's also my new boss in HEMONC, and I'm very pleased with that as well. And she, as you all know, is really an outstanding clinician scientist. And she has the, I don't know if it's an unenviable task of trying to get 7 experts to discuss their exciting cancer-related projects in a modest amount of time. But I'm sure it'll be a success. So Lisa, thank you.
So we all know that breast cancer is not one disease. It's a family of diseases that are biologically distinct from one another. They're sort of outlined here, and this, of course, is courtesy of Chuck, who's going to speak later on today. There's the molecular subtypes of breast cancer and the sort of therapeutic implications underneath it, right? So of the luminal subtypes, these are hormonally dominated, and endocrine therapy is the mainstay of treatment. There are a couple of what traditionally we consider on clinical assays, usually, although not always, triple negative for hormone receptors and HER2, in whom chemotherapy is the mainstay of treatment, and increasingly so for the HER2-enriched and HER2-dominated subtypes. HER2 targeting is effective and actually is, largely the chemotherapy is, while it's incorporated, it's becoming less and less important. So now, if this is a talk about prognostication, let's think about what exactly we want from these tests, because in truth, we use the term prognostication when sometimes we mean prognostic, which is the what is going to happen if I don't do anything, either the natural history of untreated disease or after treatment, what's going to happen from here on out if I do nothing more. Those are both prognostic tests. A predictive test, which I'm going to talk about a little bit at the very end, is totally different. It has to do with, will this intervention work? And if so, it then affects the prognosis, but it's purely through how the intervention functions. So that might be a drug. That's the most common of the profiles that are being developed. Increasingly, there are ones that are radiation or other interventional. So what do we need from these tests? And these are key things whenever you're reading about prognostic tests, prognostic profiles in particular. Are they valid? Do they do what they think they're supposed to? Are they reproducible? Are they accurate? Are they appropriate for the patient that you're going to use it in? I'll talk about that a little bit. Are they easy? And are they cost effective? That's increasingly important. So of the valid ones, and I'm just going to sort of lump things together to point out a couple of things. The first is that we have prognostic features of breast cancer that are really quite good. Stage, just before treatment, just stage up front, it is valid, it is reproducible, it's accurate, it's easy to get, and it is cheap. Stage after treatment, I'm going to show you a little bit about that, also fulfills all of those criteria. Receptors, the clinical receptors that we get on everybody anyway because we need them to make treatment decisions, are pretty good. The accuracy part falls down, as anybody, to some degree, as anybody who's been reading the literature knows. What we think of as the sort of easy ER, PR, and HER2, in fact, are frequently not as clear-cut as we'd like them to be, and that's been plaguing our field. And then the genomic profiles, which are valid, the good ones are reproducible, they are accurate. They're not easy, and they certainly aren't cheap, so we have to be very thoughtful about how we use them. So briefly, from the standpoint of stage in the untreated setting, stage does matter, and there is no prognostic profile genomic test that is going to replace stage, and you'll hear that as a sort of reiterated function throughout this talk. I'm showing you here one of the areas that we spend a lot of time debating, and that's the very small node-negative breast cancers, particularly those that have an aggressive appearing biology. And what you can see across the top, these are T1A, B, N0. So these are 1 centimeter or smaller node-negative breast cancers. And across the top, you can see the patients are doing pretty well. They were not treated. And that included triple-negative breast cancers. The yellow line is actually HER2-positive T1A, B, N0 breast cancers, and there's been a couple of data sets that suggest that in the untreated setting, HER2-positive breast cancer does act a little more aggressively and is prognostically a little bit worse. But if you take these together, you can certainly say that it's okay, not to treat small node-negative, either ER-positive or triple-negative breast cancer. The threshold is a little bit lower for HER2-positive breast cancer for these these reasons. What about post-chemotherapy? So we do know that if you give chemotherapy and the tumor is obliterated, it doesn't really matter what subtype the breast cancer started as, they're going to have a good prognosis. Among those with residual disease after chemotherapy, there's a lot of heterogeneity. And you can see here the hormone receptor positive breast cancers do better than the triple negative or the HER2 positive breast cancers, doubtless because of the intervention of endocrine therapy. Now that we routinely give HER2 targeting, doubtless those are going to go up too. But we have to keep in mind the denominator. So here you see the molecular subtypes of breast cancer that I outlined in the very beginning. And you can see if you give the same chemotherapy drugs to different subtypes of breast cancer, you will get a different likelihood of obliterating the tumor, as I showed you. So in truth, the ER-negative subtypes are actually doing quite well in terms of about a third of them will have complete obliteration of the tumor with just conventional chemotherapy. You don't have to get too fancy or involve novel therapies for these patients. The ER-positive subtypes, on the other hand, are very unlikely, particularly the luminal A's that are the most common, to have a pathologic complete response to standard chemotherapy. And in truth, this is increasingly being recognized in that the FDA is actually considering use of pathologic complete response to therapy as an endpoint for ER-negative breast cancers. Not so for ER-positive. So what about endocrine therapy? If you give endocrine therapy up front, there's emerging evidence that you can take the pathologic features of the cancer as well as some biomarkers, and you can incorporate them. So you basically have a upfront sense of the tumor, plus you have a sense of whether the drugs were effective and whether the tumor was responsive to them. And that index, which is sort of created over here, is called the PEPI, or Preoperative Endocrine Prognostic Index. And you can see the testing case of it over here, where you can see across the top is the PEPI-0, which are basically very small, node-negative, low proliferative index, and maintained hormone receptors after endocrine therapy alone, doing extremely well. And in this data set, none of them had relapsed 5 years out. And the question, of course, is can you use this kind of thing to omit chemotherapy and determine patients who will not need further treatment? So I would say the short answer is not yet, but there is a validation trial that's coming that will ask exactly that question in a prospective manner. Now we're going to turn our attention to the prognostic profiles, because I think it really is important to lay the groundwork for prognostication in breast cancer before you start getting to these profiles. Although we have a number outlined in the middle that are actually available and being used, certainly the lower two, Oncotype and Mammaprint. So the Mammaprint profile is a 70-gene profile. It was developed, using what they call a top-down approach, where they took a whole bunch of genes and found those that were most related to relapse within the first 5 years after diagnosis. A couple of things that are highlighted here. A, the Mammaprint works. It is an assay that does work for prognostication. No matter what clinical risk you model, which is basically what this shows, they model the clinical risk. And you can see that about a hazard ratio of 2-ish, so about a doubling of the risk if you have a poor risk profile using the Mammaprint test. Of course, if you have an independent contribution of the profile, you also have an independent contribution of the clinical variables, so you have to keep that in mind for all of these. Again, stage matters. And you can also say it's a modest effect. This is not, the sort of Damocles. If you have a high-risk test, that does not mean that the patient will relapse. It just increases, about doubles the likelihood of it happening. Now, how do you use this? The question, of course, is do you intervene, for example, with chemotherapy in these patients, and are they more likely to need it? We don't have those data yet. There is a large trial that's been completed in Europe called the MINDAC trial, which will provide level 1 evidence for the point at which, in this profile, chemotherapy starts to provide a real benefit. What about the Oncotype DX recurrence score, which is the most commonly used profile in this country? It's actually a very commonly used profile in part because it was the first to also allow profiling in fixed tissue. The Mammaprint was developed for frozen tissue, which of course we don't conventionally have, so it's a much harder test to use. So the recurrence score was developed in a very different methodology. They started with candidate genes and then honed it down to those that were the most relevant for prognosis in ER-positive, node-negative breast cancer patients treated with endocrine therapy. So if you think about it, the development of this was all about deciding which patients were not essentially sensitive enough to the endocrine therapy and would need chemotherapy. And you can see essentially it's a continuous variable. As the recurrence score goes up, the risk of recurrence in spite of endocrine therapy, in this case tamoxifen, also goes up. And then they sort of drop some lines to categorize them into low, intermediate, and high risk. What does it mean to have each of these? In the validation study, which was an NSABP study, you can see the low recurrence score. You only had a 7% or less than 10% risk of distant recurrence, which is, of course, the endpoint we're the most interested in. If you have a low recurrence score, high recurrence score, about 1 in 3. So this is a very real differentiator amongst a relatively homogeneous group of patients that were similarly treated. So this is a highly valid endpoint. Now, the other thing to consider, and I'll show you this, the absolute risk does vary by the clinical criteria, so it doesn't replace those, but it certainly remains across all of these nodal subsets. It's an important prognosticator. This is the kind of picture you get if you order an Oncotype DX recurrence score and you send your tumor back. You get a recurrence score. See, in this case, it was a 10, which falls down in the low category. And they also give you based on the NSABP data, what your average rate of distant recurrence at 10 years would be. Now, I've always been troubled by that number, which of course our patients focus on, because as I mentioned, the risk always varies by the clinical variables. Both tumor and node status matters for recurrence score interpretation. And here's for example, if you just take the tumor size in that study, there was a big difference between within high recurrence scores. So how do we use it? And the reason that this has had great uptake in use is because we also know that it does matter for chemotherapy benefit. Of course, if you think about it, if you had a high recurrence score and a low recurrence score, and the high recurrence score was also insensitive to chemotherapy, you would not have an intervention, and you would simply know that the patient was higher risk. You couldn't do anything about it. In truth, we do know from the recurrence score studies subsequently that the recurrence score not only predicts a higher likelihood of relapse in spite of endocrine therapy, but also a higher likelihood of responsiveness to chemotherapy. So it's a very nice circular kind of tucking in of the ends of things you actually can do to circumvent this higher risk. You see here all patients, tamoxifen alone versus tamoxifen plus chemotherapy. Low recurrence score, essentially no impact of the chemotherapy. Intermediate, very little impact of the chemotherapy. Pretty much all of the impact of chemotherapy in that study was in those patients that also had a high recurrence score. So this is why, in fact, people do use the recurrence score for chemotherapy decision making, particularly in the node negative setting, which is the one that's the most strongly modeled. There will be level 1 evidence coming for the intermediate group, are the ones that we're the least certain about. You know, the point at which you say to your patient, I'm not quite sure where exactly we start to decide to pull the trigger on chemo. There is a prospective trial that will help us with that. And there's also a prospective trial ongoing right now in node positive to help us with exactly the same decision making. What it cannot tell you, though, is which drug to use. It can tell you yes to add or not, but amongst the myriad drug regimens, the alphabet soup that we have, it does not help you with that. And then finally, we have the ROR, which is essentially a methodology for intrinsic subtyping. I assume Chuck is going to talk about that a little bit later. No, he's shaking his head. He's not going to. Essentially, it is a way of subtyping that can be done and classifying an individual tumor into one of those intrinsic subtypes I showed in the very beginning, the basal-like HER2-enriched luminal A and luminal B. And if you can do that, you can see the high, low, medium, you have a very nice separation of risk over time in a large group of patients that were node negative and untreated. So finally, how do you choose these? So if we are going to incorporate genomic profiles, first off, only the recurrence score at this point is validated to not only prognosticate, but also show you chemotherapy benefit, that predictive element of it, which is so valuable and is in fact the reason that we're getting the test. So the answer right now is very easy. But the recurrence score also appears to be mostly useful in the luminal A subtype, as seen here. It really separates out those luminal A's very nicely. Most of the luminal B's, which are the other main component of ER-positive breast cancer, are a high recurrence score. It's not adding a lot for them. So do you do both? I mean, these are $3,000 tests. We don't actually know what the ROR test is going to end up costing once NanoString decides to commercialize it, but it's not going to be cheap. And the recurrence score costs about $3,500. So now you're maybe talking about a $7,000 assessment of a tumor. So do you need to do that? We do have some information that came from the ATAC trial, purely from the prognostication standpoint, not from the chemotherapy benefit. But in the ATAC trial, which is a very large adjuvant trial where they were examining endocrine therapy maneuvers, either an aromatase inhibitor or tamoxifen, they also did a subset of these examining recurrence scores. And they found the risk of recurrence, or ROR score, worked. So did the recurrence score. They both worked for prognostication. Adding the ROR to the recurrence score did seem to provide independent prognostic information. The converse was not true. So it may be that this will help us with decision making. Again, we don't have chemotherapy information as yet, but this is the kind of study that's going to need to be done with comparisons and figuring out what additive benefit you actually get for the extra bang for the buck. Now, of course, we have to keep in mind these tests are not for all tumors. So this is an exhaustive effort with a variety of profiles. A few I named, and then a bunch more that I'm not naming, where they looked at different subtypes of breast cancer. And if you look at multiple genetic assays, in general, ER positive, they tended to work. They've been validated. They are useful. ER negative, they don't work. HER2 positive, they don't work. So these are really tests for ER positive, HER2 negative breast cancer. Now, the predictive part of this talk is short, and that's because there aren't any real predictive profiles. Prediction is done by ER, PR, and HER2, and that's all we have at the moment. There's a lot of them coming down the pike. I've added some here. There's now a radiation one that's been tested, but is not yet validated. So it's coming, but it's not here and not ready for the clinic. So finally, what's been the impact of these kind of profiles in clinical decision making? We don't really know yet because we're still early on, but you can say that in general over time, and this goes up to 2008, testing has gone up. So profiling in hormone receptor positive breast cancer, which is of course the appropriate use of the test, increased from 15% to 28%. At the same time, chemotherapy use decreased from 54% down to 47%. So if you're paying $3,500 to not give chemotherapy, which costs a lot more both in the personal life of the patient as well as the price of the drugs, this actually may be a very cost-effective approach. So to summarize, prognostic profiles are quite feasible, appropriate in hormone receptor positive, HER2 negative breast cancer. We do use them, and they're reasonable to do so in guiding therapeutic decisions. Unfortunately, we don't have any such thing for ER negative or HER2 positive breast cancer. We do know a little bit about prognosis, and we use all of our staging information the old-fashioned way now. And that is the end of my talk. Thank you very much. Appreciate it.